So, μου ζήτησε η Γεωργία να μιλήσω για imaging of tuberculosis in children, the chest and more. Αλλά το and more το έβαλα σε παρένθεση και δεν θα το κάνουμε. Θα το κόψουμε επειδή δεν θα τα φτάσουμε. Okay. Δεν το ετοίμασα. Next year να με ξανακαλέσετε. Okay. So let's start with the problem. We need a problem that we need to solve to be important or to be useful. I put 3 X-rays for you. Maybe you think the one on the left is normal. I'm trying to tell you it's normal. It's as normal as I think you can get, a decent quality radiograph. But the 2 radiographs on the right are both abnormal, okay? And this is what the AI tools will do for you at the moment. They will tell you that the X-ray is abnormal. They can point at the parenchymal abnormality, but tuberculosis is a different story. Δεν θέλουμε μόνο να ξέρουμε πως είναι κάτι έχει το παιδί. Θέλουμε να ξέρουμε αν έχει tuberculosis. Okay? So, το ένα αυτό βλέπουμε consolidation, airspace disease, πώς τα λέτε εσείς. Και το άλλο, the same thing at the lower lobe, the one in the middle lobe, one in the lower lobe. One of these is tuberculosis, one is just pneumonia. Okay, so you're supposed to make the difference because the treatment is completely different. The one child will get treatment for a week, the other one will get treatment for 6 months, okay, and completely different drugs. And you need to do this because you think maybe that the clinician can solve the problem, but the clinician can only solve the problem somewhere between 10 and 20% of the time, where they can get something sputum, most of the time they cannot, and where they can get that sputum to give you an organism, and most of the time they cannot. Okay? Even with new techniques, with Gene Expert and all the bronchial lavage, still the success rate is 20%. So actually you have to do it with the X-ray. That's the pneumonia, that's the TB, if you were wondering, and I'm not sure if you can do that yourself. Okay? It's a difficult job, and I'm going to try and help us with this job. So the first thing I have to say is that the chest X-ray is useless for TB. It's useless because you cannot rely on it. Not because it cannot do the job, okay? So the job, you can see what you need to see, and I will show you how to do that. So I'm not saying don't do the X-ray, but I don't rely on an X-ray myself. And I've got 20 years experience of reading TB X-rays. Even at the moment, even as a side job, I read for 4 AI projects that need reportings to prove what they are doing is working and whatnot. And even now I have a lot of trouble. So we're trying to diagnose an organism, not that the X-ray is abnormal. And you don't do that for anything else. You don't go, this is mycoplasma, this is pneumococcus, this is staphylococcus. You just go, the X-ray, there's airspace, consolidation, treat with antibiotics. To do that, we are using a surrogate. So we are not using the parenchymal disease or something to do with the organism. We're looking for lymphadenopathy, which is a surrogate. It tells you maybe you have TB, but there are many causes of lymphadenopathy, okay? So our marker is lymphadenopathy, and it's not a very good one. And as you know, the X-ray is black and white. I'm just going to turn myself to the side because as I get older, it's even better. You know, I'm not a flat page. Είμαι ένα κουτί. Δεν είμαι σελίδα. Okay? So όλα που μένει μέσα εδώ είναι flattened into one picture on top of each other with the X-ray. And in fact, that doesn't help us at all because the hilum and the mediastinum and the heart is all one thing on an X-ray, one white thing in the middle. So I think you can only evaluate for lymphadenopathy from the contour of the mediastinum and how it looks, and I will show you how to do that. But if you do the numbers and you do the tests, there are hundreds of projects now. From the time we did it in 2003, αυτό που βλέπετε με Swingler, ένα που έκαναμε με το Swingler, to latest ones, Bertolud, Seddon, the success is very poor. So when you do specificity, αυτό που σας λέει, the true negative, okay, it's 50%. To me, this is a useless test. If you cannot tell the patient you do not have TB, go home. As opposed to, you really don't have TB, go home. So the other bad thing is when they do CT scans, and a lot of people don't do that, and that's the problem with the AI tools. Everyone is annotating AI tools on the X-ray, not with a CT backup. And nobody's doing CT. When they did CT on a few patients, 60% of TB-infected children with normal chest X-ray, δηλαδή αυτό που λέμε, το είπανε true negative, το βάλανε normal, it's not a true negative, it's a false negative. They had something abnormal on CT and they had lymphadenopathy. And the Turkish group did the same thing the other way around. They called a bunch of abnormal x-rays, and they had symptoms, everything together. Symptoms, abnormal x-rays, 6 months treatment. You do the CT scan, there's nothing there. We imagined it, okay? The best thing to look at is reliability, okay, kappa. Is the lowest reliability of anything, of any type of infection. The lowest reliability is for pediatric TB. And it's completely different from adult TB, so don't look at it. It's a completely different part of the chest. So reliability, very bad for overall diagnosis. And specifically for the one thing you're supposed to look at, it's even worse. For lymphadenopathy, the reliability is terrible. It's terrible. If you look at the scale, Cathomas testo, none to minimal. Okay. So why would you use this X-ray tool for TB? Okay. So what you can do, it was used for this in the past. They were looking for calcification, right? They were looking for calcified lymph nodes and calcified gone focus, gone complex, whatever you call it. But you don't see calcification anymore, almost at all. And I'm not sure if it's an evolution of when we pick it up or the treatment of TB, but you see not even 1%. Maybe you would see more with a CAT scan. But we hardly ever see calcification. I've been reading now, last year, I haven't called one calcification in 4 TB trials. Okay. So it's very rare. If you see it, no problem. It's very easy to see, you can call. The problem with this, they used to look for calcification to say, you don't have active TB. It's calcified. You have dormant TB. Okay? And we don't use those words anymore, but that's what they used it for. Anyway, look for it, but it makes no difference. You're not going to see it. So let's not waste our time. So how do you diagnose TB on a chest X-ray with confidence? That's the part I can show you today. You know, otherwise, please use your CAT scanner and your MRI scanner. So let's say in the appropriate clinical setting, okay, TB on chest X-ray in children is lymphadenopathy. And that's the problem with the AI tools they show you. They pick up things in the parenchyma, and they keep looking for things in the parenchyma. And that's not really what pediatric TB is. They're supposed to be looking for things on the contour of the mediastinum. So both these children have TB. Both these children have probably got the best example of an X-ray for, say, this child has TB, okay? And the place to look is the hilum, okay? You can see these are bulky, outwardly convex, soft tissue masses where you expect to see blood vessels diverging, separating from each other. And the other side is possibly the same. This patient a little bit less obvious, but again, it's convex on the outside, and that side is convex on the outside instead of concave. And I will show you against the normal in a minute. So this is what you want to do. You want to pick up hilar lymphadenopathy if you can. In this, we would be correct, you would be correct, and we would agree 100% maybe, but 90% of the X-rays don't look like this. Okay. So here's what I'm calling a normal X-ray for an example. Okay, you look at the hilum. The hilum, the vessels diverge. Where they meet, we call it the hilar point. It should be concave. This is the TB case, the one with the big obvious nodes. You cover the contour, it's like a cauliflower or whatever. It's like a bunch of fruit, a bunch of grapes, whatever, in a soft tissue masses. On the other side, to show you when you can see the left hilum, because most of the time it's hidden behind the heart and the mediastinum, it should again be concave. And if you look on the second case, which was not so obvious, again, if it's bulging outwards, you may have lymphadenopathy. I'm not sure if we were accurate there or not. Okay? Okay, so some important warnings. You're all asking yourself, not all lymphadenopathy is TB is true, right? We've treated a bunch of lymphoma cases as TB until we decided they were lymphoma, right? So here's two. One is TB, one is lymphoma. What's the difference, right? Big, wide mediastinum. The trachea is displaced to the opposite side, towards the left. You have hilar masses, big, so there. Okay, which one's lymphoma, which one's TB? I don't know. They both have lymphadenopathy. So this has all got to be contextualized, right? How does the patient present? Is it a chronic cough? Do the parents have TB? Or we're talking about something different that makes you think of a tumor like lymphoma, leukemia, etc. Okay, so that was the lymphoma, that was the TB. I cannot tell the difference myself on the radiograph, right? They're just lymphadenopathy. You have the thymus issue. And if you're all pediatric radiologists, no problem. But we have students here, we have general radiologists. The thymus is an issue. It's a thing in the anterior mediastinum, superior anterior mediastinum. But if you're a radiologist and you see this, a typical sail, what we call the spinnaker sail, if you don't do sailing, what is the spinnaker? Ένα πανί, ενός σκάφου, τα υβρά. Μπράβο μου, το έκανα προπόνηση αυτό. And this one too, this is a typical sign. It's got a wavy margin of the thymus. Why is it wavy? Because it's anterior, it's pushing up against the ribs, and the thymus is supposed to be soft. So the thymus, the thymus is the child in the playground that's getting bullied. He never bullies anybody, right? So every part he pushes on the thymus. The thymus cannot push on anybody. But when you have disease, the disease is pushing on everybody. The disease is the bully, okay? So a lateral view, so you can see we have a typical sign sometimes, we have wavy margins sometimes, and we know it's anterior and superior, okay? So this is what the thymus, if you are lucky. And again, to show you using the cross-sectional, if you have a cross-sectional, it's easy. Thymus is homogeneous, it's in the right place. And if you see the vessels push into the thymus doesn't push into the vessels. When you have pathology, like lymphadenopathy, the lymphadenopathy pushes on the veins, it pushes on the trachea from side to side. So the disease pushes people around. The thymus never pushes things around. On the MRI, the same. The heart pushes into the thymus. If you have a lymphadenopathy or a mass, it can push into the vessels and it does the pushing. So thymus is bilocation. You know what it is. You know they don't compress anything, but it is compressible if it's normal. And this is a problem you have to solve, and we don't always solve it. Sometimes we take an ultrasound probe and we look and see, oh, that's normal thymus, okay? So it's not always solvable. And another problem, the sicker patients are the worst things are for you for making a diagnosis of TB. So when they have consolidation or airspace disease, well, where is the hilum if it's obscured by airspace disease? So how are you supposed to talk about the hilum if it's obscured? So on the first picture on your left, you see the hilum is obscured by whatever. Is that left lower lobe and, right lower lobe and right middle lobe together? There's diaphragm missing, there's cardiac margin missing. On the other picture, you have left lower lobe and lingular, so you can't see the left hilum. So who knows which is the TB? So I can show you why I think the one is TB or not, but in fact, it turns out the one is TB, the one's just the pneumonia. The consolidation looks the same, and the hilum is hidden. How are you supposed to do your job? So I want to give you some scenarios to add confidence. You want to improve the way you make a diagnosis on the chest X-ray, and there's 3 things I can tell you before I tell you to go to MRI and CT, okay? And let's be honest about it. If you have a population like South Africa where whatever, more than 2/3 of the population have tuberculosis or something crazy, and you've got 60 million people, you're never going to do MRI and CT on everybody. But if you're here and you have a couple of migrants and they say, oh, we think the patient just came from Malawi with the parents and everybody's sick and the mother's positive, you can use your cross-sectional. It's one patient, you know. So use the lateral film. Do you do lateral in Greece? For children? Not routinely, okay. So in England, they stopped doing lateral. In South Africa, in America, everybody gets a lateral, okay? So some people don't know how to read a lateral in a child. In England, nobody. You show them this, they go, what's that, okay? So I'm going to show you some things. If you have a TB patient, I advise you to get a lateral. Okay, suspected TB, travel, a migrant, patient looking for citizenship, a patient who's sick and parents tested positive across the road, something like that. So where I put the C is where the carina is. It's not lower down. Where you see the circle, that's where the right upper lobe bronchus came off. Where the right upper lobe bronchus came off is just after the carina. So that is the carina where the trachea splits, okay, where the C is, where that little circle is, which means the airway below that is bronchus intermedius. Most of it is bronchus intermedius, that. There should be nothing behind the bronchus intermedius. There should be nothing underneath the carina, except for vessels separating, okay? So when you have lymphadenopathy, it looks like, we call it the donut sign, you know, to help Americans because they eat donuts. But really, this is probably the best donut I have, so they don't all look like this. But just to show you, that's the donut. It's this bit that's important. There should be no mass there, and should be no mass behind the bronchus intermedius. All the bits on top, though, could be normal structures, okay? So just to summarize that, that's the normal structures on the lateral. They make a semicircle, okay, or a horseshoe on top. So the aorta, the right main and the left main pulmonary artery, they all do a semicircle. Below that, you should just have vessels separating, okay? No masses, okay? And if you have lymphadenopathy, of course, it's a donut, and I've shown you that. Okay. The last thing and most important thing for me to give you as advice is the airway is very soft in kids compared to adults, and lymphadenopathy from TB compresses the airway. And I'm telling you, the airway is a surrogate of the surrogate. There, something you use that as a negative thought. I don't see the lymph nodes, but because the airway is compressed, they may have lymph nodes. I don't know it's TB, but because they have lymphadenopathy, it's TB. So it's 2 steps, but they're very important steps. I believe the airway is the most successful way to know you have lymphadenopathy, because the airway is the only dark thing in the mediastinum. Okay? So you can watch if it deviates, and you can watch if it compresses. So I'll give you some examples. That's the main parts of the airway. I'm just talking about the proximal parts of the airway, not the distal airways. Just remember, you have an aorta on the left, so your trachea in children should be to the right. If your trachea is centralized and the patient is straight, not rotated, and if you see any obvious airway compressions, you see it gets narrow and then it gets wide again, you suspect lymphadenopathy. This is the same patient with those big fat masses. So we saw lymph nodes and we see the airway, we have a lot of confidence, okay? Now I'm going to show you a patient, the trachea is also displaced, but you can argue about that. This is a patient where there's no big lymph node masses at the hilum. I don't see anything at the hilum. But if you look carefully, the one on the left is your normal, as your baseline, and the one on the right, you can see those airways. Narrow bronchus intermedius, the commonest site. Narrow left main bronchus, very common site. How do I know they're narrow? Because the left main bronchus becomes bigger again, more distally. You know, trees don't go thick, thin, and then thin, thick again. You know, they go thinner as you get wider. So this is a bronchial tree, and I suggest you look at your airway religiously for tuberculosis. If you have a patient with miliary nodules, that's another definitive sign. It's not common. It means the TB is in the bloodstream. It's just like metastases, okay? But these are metastases, tiny, small nodules, not linearities. So there are not a lot of causes that you see commonly of diffuse lung disease with interstitial pattern in children, and especially not a lot of causes of nodularity. So if you have a question about a patient and the mother tested positive, again, the right clinical scenario, where do you look to be sure these are not blood vessels? As usual, look at the periphery. You know, you shouldn't see blood vessels completely to the end of the lung. If you see nodules in the outer third, I recommend you look behind the sternum as well, despite the fact that there can be a thymus. In TB children, the thymus is shrunk, and sometimes you can see the nodules. So these are great places to look to say, oh, I do think those are nodules. Look in the costophrenic angles, look retrosternal. Just to remind junior people, consolidation, air-space disease, pneumonia, it confluences. It comes together like the clouds. When you look in the sky, the clouds come together, you get rain. Miliary nodules, you lie at night and you look at the sky when you're out in the countryside. It doesn't matter how many stars, they never join together. Okay? So just another example of miliary nodules, easier to see on this patient, right? Okay. Is there a better way to make the diagnosis? I just told you X-ray was bad. I'm trying to help you with the X-ray as much as I can. Of course, there are better ways to do it. Not X-ray, CT and MRI, okay? So CT is a one-stop shop, okay? We say it for many things. There are dose considerations. I don't want to make you use it like crazy on everybody with the highest dose. But you have a fantastic tool, and if we're going to guess what diagnosis the patients have, instead of guessing and putting them on 6 months treatment, have you tried to put your kids on a week's antibiotics? You try to give your own children a week's antibiotics. Cheapest. By the 4th day, we're ready to give up, right? And I've been doing it for 5 years. Imagine giving children antibiotics, 6 different drugs a day for 6 months. Imagine. In a rural place where they don't even know what disease is. It's crazy stuff, right? So you want to make sure you have a diagnosis. You detect lymph nodes very easily. You characterize them. So these lymph nodes have got the typical characteristic. Low density with a rim enhancement. Very typical of TB on CT. But you also see complications, okay? And what I show you here again, where I was teaching you to look at the airway for diagnosing TB, Of course, the airway compression is a complication of TB. And it's a very important one and a very common one, and people don't talk about it. The condition is called lymphobronchial TB. It means the lymph nodes are compressing the airways. And you will see as I progress through this talk, which is not going to be that long, that airway compression is not just important for diagnosis. It's important because distant to a bronchial compression. So have a look at the coronal. On the left picture, you can see parenchymal disease with some necrosis. Now, if you look at the coronal in this particular patient, there's 3 areas of bronchial compression. But the right upper lobe bronchus is completely obstructed, okay? And you see the parenchyma in the right upper lobe. There's an area with breakdown, and there's an area that's not enhancing. Those are non-recoverable areas. That is our grading. We've written this paper in the right-hand corner, grading the parenchymal disease distal to an obstruction of a bronchus, okay? That is destroyed lung. If you catch the bronchial narrowing at the bronchus intermediate stage, at the left main bronchus, you can go in, the surgeons go in and enucleate, it's called. They take out a lymph node, suck out some lymph nodes, open the airway, or they do endobronchial cleaning and sucking, and you can prevent parenchymal permanent damage, okay? So, 30% of TB, when we did CT scans on 100 children with the one study in 2003, 30% of children without respiratory symptoms have airway compression on CT, okay, from the lymph nodes. A different study, when every single patient with airway symptoms, stridor, wheezing, had visible airway compression on CT, okay? And then this particular paper we've written is to tell people you've got to catch this airway compression before the parenchyma dies. That means the parenchyma should still be enhancing to be vital or alive. So you've got to get these lymph nodes cleared away before you kill lung that you're never going to get back. Okay. So the next thing I'd recommend, if you have MRI and you're thinking about fast MRI for other things. So I do lots of neuro. I'm thinking about fast MRIs for headaches, fast MRI, whatever, for hydrocephalus follow-up. You limit the time on the scanner. You hope that you do not need anesthesia, and you start to use your MRI scanner for more acute things where they would have had CT and worse imaging, maybe worse imaging, depending on the indication. So we have tried MRI for under 10-minute scans. You don't need the full 10 minutes. You just do stir and DWI, okay? But if you have 10 minutes on the table and the patient is not moving, you can try T2 and another DWI and a different plane of stir, and that's what we did. We had like an 80% success rate without sedation, keeping in mind that children with TB are like between 3 and 8 years of age. You know, but the 3-year-olds don't like lying still, but the 6-year-olds, the 7-year-olds, the 8-year-olds, they'll lie still. For 10 minutes, you can keep them down. You can repeat a few sequences in your 10-minute period, and you get to see a lot of things. And the one thing we've discovered is that lymph nodes of TB compared to other lymph nodes on MRI. So most lymphadenopathy on MRI is bright on stir. If you do MRI for lymphoma, you look for bright signal, okay, except for one histological type. But the TB nodes are black. And it's the same necrosis that's happening for TB granuloma in the brain. If you have a look at all the papers, if you want to make a distinction of TB granuloma from an abscess, you know, on T2, the TB granuloma is black, the abscess is bright, okay? So MRI detection without anesthesia and characterization is like a biomarker. You can't really be anything else, okay? Except for calcified nodes, I guess. So the last thing I'm going to tell you is that you can try ultrasound. I don't know if any of you have done ultrasound of the mediastinum. We've written 2 papers. One's technical, one was a test, and now we've done a subsequent paper where we've compared against other tools and size of lymphadenopathy and whatnot, which I haven't shown here. But you can do ultrasound through the suprasternal notch, okay? Not too difficult. You take one of these cranial ultrasound probes or these hockey stick probes or anything small that you can fit in the suprasternal notch. You turn the baby's head to the left, the child's head to the left, so you can tilt your probe up without hitting him in the chin. So you can look into the chest. It comes out like a coronal oblique, okay? And it looks something like this. So I put the schematic so you can see. The closest thing to your probe is the thymus because it's most superficial. Then come the veins, then come the arteries. The blue bit is the potential lymphadenopathy for you, okay? The dark bits on this normal is just your vessels. I've labeled your veins, superior vena cava, brachiocephalic veins, the aorta, and the pulmonary artery. Okay. Now, if you turn the probe slightly anti-clockwise, the opposite direction to the clock, you will be going along the aortic arch. So imagine how the aortic arch goes from front to back. And you get this picture of the aortic arch. You get a second picture, and you look at the aortopulmonary window, just that space of fat deep to the aortic arch. Now I will show you some lymph nodes so you can believe me. The normal is on the left, the lymph nodes on the right. Lymph nodes are dark, okay, but they're not anechoic like blood. Okay, they're dark. You can put on your blood your color, but when you do it real life, it's crazy because there's too much motion and too much stuff going on. So you don't really want to do that. There's a lymph node, a bunch of lymph nodes there, a lymph node between the vessels, and one in the aortopulmonary window. It doesn't work every time. I went to the Philippines. They brought 6 children. I didn't get it right in front of the audience in any of them. It was a bit embarrassing. But anyway, I'm used to not succeeding in everything we do. So this is the last thing I'm going to talk about, okay? This is the new thing. So if everything else you've seen before, you haven't seen this part of the talk, because these are new guidelines that came out in 2022, and we didn't have a lot of time to think about it, but eventually I read them, and eventually we have some commentary that's in pediatric radiology. I don't know if anyone's noticed, but it matters. Because what happened is they made one big trial called the SHINE trial, and they managed to treat children with 3 months treatment, okay? And the standard now is 3 months treatment unless you have severe TB. So what we need to know is, what is severe TB? How do I diagnose severe TB? Because they cannot get 3 months. They must get 6 months, okay? And it's your job. It's on the X-ray. And that's what you should know. And suddenly, the X-ray matters. And that's what I'm saying in this paper. Because we are not looking for the lymph nodes anymore, which you have poor agreement, poor specificity. We are looking for things that you can see well. Effusions, airway compression, etc. So let me just run through that quickly. People are dozing off. It's killing me. Okay. The history of TB, pre-chemotherapy, before we had the drugs, post-chemotherapy, after 1940, we had some drugs to treat, and now the new short course. And that is, I've divided the last bit. It's a new era of treatment. So what did we do for patients? We didn't have drugs, so you had to find the patients you needed to put in isolation in those hospitals next to the sea. You have those beds outside at the sea. And you had to work out the patients who were not going to get treated. And all you had the job to do was look if there was calcification. Then we have the treatment, the drug TB treatment. So you've got to now find on X-ray anybody with lymphadenopathy so you can give them the treatment. Okay, so that's what changed. That's what we've been doing until now. My whole life, that's all I do. Look for lymph nodes. If they have lymphadenopathy, we give them the treatment. And of course, now we've got to work out who doesn't get the short treatment. And at least if you can do the last one, I'll be very happy, okay? So the patients with calcification back then, you would not have to isolate them. They were dormant. When you got to this stage, all you had to do was find lymphadenopathy. The X-ray is doing a bad job, I've shown you. And now we can do a good job, because severe is anybody with effusion, anybody with miliary, anybody with airway compression, anybody with cavitation, or anybody with multiple lobes of lung involved. And I think all of those are easy, and we agree with each other much more often than for lymphadenopathy. Our kappas for effusion are much higher. Kappa for airway compression is much higher. Just a few examples of what cannot qualify for short course. These patients will all get 6 months. So I'm pointing, the trachea is deviated. The left main bronchus is narrow, and we have lymph nodes on the left. So patient with lymphadenopathy and airway compression cannot get short course. The other patient has cavitation and airway compression. 2 reasons not to have short course. This patient has effusion, multiple lobes, and airway compression, cannot get short course. And the last one has miliary nodules, cannot get short course. All are called severe TB. Every single reporting template that I've published has now been corrected to say if you have severe TB or not severe TB. All the AI projects that we are doing, helping with, all say that now. They have to do that on the AI tool because it matters for treatment. So that's the end. Don't expect too much from the X-ray. Your job's to diagnose lymphadenopathy. There's a couple of ways to improve it. Use the lateral, look at the airway, look for miliary nodules. But actually, please use your cross-sectional. You'll be doing me a favor. And the new role for chest X-ray is to decide short versus long treatment. If they have any of those severe things, they do not get the short treatment. Thank you.